Okay, good. Well, welcome to the 16th Grand Rounds of the International Uveitis Study Group. Um, we're having we're changing from sort of diagnoses to sort of treatment strategies for today and the next webinar, which is not for 3 more months, as we take sort of the Northern Hemisphere summer off. But we appreciate everyone's interest and welcome. Today we have an exciting group of cases and thematic lecture and discussion by experts as usual. And so let's go ahead and begin the webinar.
Yeah, well, good morning. Thank you, good morning, good evening, and good afternoon. Our first speaker is going to be giving our thematic lecture, and that's Dr. Miguel Cordero Coma. He is a uveitis and medical retina specialist at the hospital at the University of Malaga in Spain. And we are so lucky to have him to discuss with us practical tips of immunosuppression.
Are you seeing it okay?
De acuerdo.
Yes.
Okay, so good morning, good afternoon, and good evening to everyone. I would like to thank you all for standing over there. This is Miguel Cordero Coma from Spain, and also thanks to the IUSG for their kind invitation to be here today. I will start my lecture regarding specific problems regarding treatment of non-infectious uveitis. As you know, this is an heterogeneous condition with many different clinical pictures under the same umbrella term. The second and third is the absence of universally accepted therapeutic guidelines and, of course, guidelines for treatment response and monitoring. And finally, there are few treatment options, and as you know, most of them are use off-label. When comparing anterior with non-anterior non-infectious uveitis, in anterior uveitis patients, the disease course, as you know, is limited with a lower incidence of ocular complications, with a better overall prognosis and with topical treatment being effective. That's why these patients are treated initially with topical treatments with systemic therapy reserved for selected cases. On the other hand, non-anterior uveitis patients have a prolonged disease course with higher incidence of ocular complications, with a worse overall prognosis, and with topical treatment with limited efficacy. And that's why we initially treat these patients with systemic therapy with intraocular and surgery preserved for selected cases. So the classic management of non-infectious uveitis can be summarized in this step-ladder algorithm in which steroids were the initial common therapy for all our patients. For those patients with severe vision-threatening entities, we can use classic immunosuppressive medication or even alkylating agents. And of course, coadjuvant therapy could be used by the clinician at their discretion. So in this classic algorithm, in this classic management, systemic steroids were the mainstay of treatment. And I would like to point out that this is an anti-inflammatory medication with no immunomodulation and no modification of the natural history of the disease. And also, as you know, systemic steroids are associated with many side effects, and from an effectivity perspective, they are linked to a tachyphylaxis phenomenon with increasing doses needed in the long term to maintain the same effect. If we analyze causes of long-term vision loss in uveitis, we see that macular damage remain as the main risk factor. So there are many others, but macular damage is one of the most important ones. And in this point of my lecture, I want to bring out this question that is really important. When immunotherapy is needed? Well, my answer to this question is soon enough. Why? Well, our goal should be preservation of function in our patients. And to preserve function, for example, in cases of macular edema, we need to act in early stages of the disease when inflammation is reversible. If we act in later stages, there will be an structural damage with atrophy of the external layers of the retina, with fibrosis, and this situation will be irreversible. So the Focus initiative bring out some indications for initiating systemic therapy. This can help us to decide when to initiate this therapy regarding 4 aspects: ocular and anatomic, therapeutic, severity in both adults and childs, especially regarding JIA. So these indications can help to decide when to start systemic therapy. Sometimes this is not an easy thing. And there will be many factors influencing the choice of immunosuppressive medication in our patients with non-infectious uveitis. Some of these factors will be related with patient characteristics, like, for example, uveitis diagnosis, severity, and there will be some other factors which are not related with the patient, like, for example, our experience with therapies, the costs, safety, etc. In the Spanish Society of Uveitis, some years ago, we initiated a big project trying to bring us a document with treatment recommendations for systemic therapy in the context of anterior and both anterior and non-anterior uveitis patients. And this was also supported by some other societies like the Spanish Society of Rheumatology, of Immunology, and of Internal Medicine. This was a huge project with a previous systematic review, with some meetings of experts panels, and with 2 Delphi rounds and a final external evaluation. I bring this with me in this lecture because you can find in these documents some statements that can help you to decide what to do with these difficult patients. And all these statements bring us a level of evidence, a recommendation grade, and a level of agreement. And all these statements will be followed by some explanations of what is stated in this statement. So about the steroids, for example, in this slide regarding pars planitis, how to use steroids. You can use either in bolus or in oral administration, and of course everything supported by available literature, and also some explanations regarding a potential IMT agent of choice that we don't have now, but some discussion about how to proceed with these difficult patients. So these kind of documents can help us to make a decision making in these difficult patients. About conventional immunomodulators and immunosuppressants, you know that most of them are used off-label, except in cyclosporin, with limited efficacy when compared to steroids, and they are associated with potentially significant side effects. But the most important thing when talking about this kind of treatments is efficacy over time, which is not very high, but is even lower when we analyze results, including a low associated dose of steroids. So efficacy with low steroids is even lower. And this led to the use of biologic agents worldwide by many clinicians because of the observed efficacy, first with anti-TNF-alpha medication and then with some other biologics. But the use of biologics was not only because of efficacy, but because of some other reasons, like in this paper, our colleagues point out recently. So if we compare the results in tolerability, in safety, in patient preference of adalimumab and infliximab with those obtained with some other conventional immunosuppressive medications like methotrexate, mycophenolate, or azacitidine, the results in ADA and infliximab are significantly higher. And the third reason for this worldwide use of biologic agents is quality of life. In this old paper, in really difficult type of patients like those with Behçet's-associated uveitis, the arrival of infliximab make a really significant improvement in all these items regarding quality of life before and after the arrival of infliximab in their therapy. So this led to the approval initially of adalimumab and especially to a wild use of these biologic agents in some difficult cases of non-infectious uveitis. So the arrival of biologics has changed the way to manage all these difficult patients with severe vision-threatening entities, in which biologic agents can be used early on as needed, and they have displaced the alkylating agents. And this is used now only in a really few number of patients. Some tips can help to decide who should be treated and when should be treated with biologics. So there will be some factors favoring the use of biologic therapy, like for example, if our patients are refractory to conventional therapy, if they have poor visual acuity, if they have a bilateral disease in a working age scenario with a theoretically aggressive associated diseases, like for example Behçet, with aggressive clinical courses versus mild to moderate clinical courses, and in the context of associated conditions contraindicated and or difficulting the use of steroids and or conventional immunosuppressive medication, like for example in the context of diabetes and or obesity. The Focus initiative bring us these tables regarding all the available biologic agents with their evidence level and recommendation level at that point. Of course, the only one with an A recommendation level because of their approval and their RCTs was adalimumab, but there is an increased use worldwide of some of this biologic therapy, and now this has been something that has been extended throughout the uveitis specialist. If we attend to a clinical profile excluding issues unrelated to medicine like higher cost, bureaucracy, legal issues, etc., and of course excluding the need to follow an orthodox algorithm, if we only attend to a clinical profile, I want to bring with me some tips of how to proceed in patients with certain clinical scenarios and how to choose our therapy of election. So if we deal with a patient with a panuveitis associated with Behçet's disease, which is refractory to cyclosporine and steroids, with predominant signs being vitritis and retinal vasculitis, this is a perfect example of how anti-TNF-alpha medication can have an impressive result. So in this patient, after 2 months of adalimumab therapy, as you can see, there was almost a complete resolution of clinical signs. But if we move to another type of patients, like patients with Behçet retinochoroidopathy with a long-standing cystoid macular edema, with low grade of vitritis. In this context, blocking IL-6 can be a better choice. So in this long-standing cystoid macular edema, we have observed an impressive response with complete resolution in many cases. And as you can see here, this long-standing edema, as mentioned before, follows an atrophy, especially affecting external layers of the retina. And there will be some other patients with really difficult situations, like this patient with Sussex syndrome, in which to generalize a certain decision is much more difficult. So in these cases, we need to do an individualized therapeutic approach. So tailored therapy will be our choice, because it's very difficult to generalize what to do in this context. And when to evaluate treatment efficacy. So time needed is somewhat variable and probably influenced by many factors, like underlying condition, location and severity of uveitis, on if there is any associated immunosuppressive medication. And of course, we need to check if there is a proper use, because this is required for a correct evaluation. And if the patient is administrating correctly the drug with correct dosing, and if there is a responsibility in maintaining fixed intervals. So time will vary from 1 to 3 months, sometimes less, sometimes more, and probably less in biologics when compared with classic immunosuppressive medication that usually requires more time to clearly assess treatment response. We will find some paradoxical situation, like in this case, in which the best eye is the eye which is inflamed. So in this case, our goal should be a good response in the best eye. So we don't mind if the left is controlled, but our goal is to preserve function in the best eye. And how to evaluate treatment efficacy. So a thorough clinical examination evaluating visual acuity, inflammatory activity scores, usually following the SUN initiative, central macular thickness with an OCT, and sometimes also with an fluorescein angiogram. And of course, changes in retinal vasculature, looking for active vasculitis with an fluorescein angiogram, and some other complementary tests, such as autofluorescence, visual field electroretinography, that should be performed at the discretion of the clinician. So the message here is that in our patients with non-infectious uveitis, and especially with this uveitis is affecting the posterior segment, like in this case of multiple Van White dot syndrome, we need a multimodal approach with many data coming from all these tests that will give us the opportunity for a more in-depth evaluation with more data, and of course with a better way for doing a monitor and treatment decision making of this kind of patients. And sometimes we will need to define concepts like a complete response, partial response, and no response. And I bring this slide with me because in certain papers we had a really difficulty by including these concepts, because as you know, the current scales for disease activity are not including the results of some tests, and these results sometimes are crucial for evaluating the response. And of course, in the project I mentioned before, we need to previously define some crucial concepts like activity, like worsening, like therapeutic failure, because these definitions are going to give us a more complete and comprehensive way to evaluate treatment response and monitoring. So in my lecture, I want to emphasize that there is an unmet need regarding the development of an activity disease score in our uveitis patients, incorporating data from many tests and thus giving us a more complete vision of what is going on our patients, on how are these patients responding to therapy. And about monitoring safety, uveitis specialists can initiate the treatment independently or in a multidisciplinary approach. Of course, checking infectious diseases as well as the clinical status of the patient before and of course during treatment, and follow recommendations and avoid live vaccines. This is really summarized because we don't have time, but I want also to point out how important is this multidisciplinary approach, because this is giving us the opportunity to share the burden of management, to share the understanding of inflammatory disease with a prompt referral, and of course with earlier diagnosis and treatment initiation. And about maintenance therapy and interpretation of results, a word about measuring certain levels of drug and antibodies against drug. Well, we have been working on adalimumab therapy on this stuff, but this can be applied to many other biologics and no biologics treatments. Try to giving us more information and how to and also giving us the opportunity to discern causes for non-response or a partial response in our patients. And because this can be related to immunogenicity, to a low dosing, or sometimes because the patient is refractory to the mechanism of action of the drug, and sometimes also this can help us to discern when the patient is not administration correctly the drug. Also, this can give us the opportunity that has not been done yet for establishing a therapeutic range, and of course helping decision making for optimization and discontinuation in some patients. So this slide is just to emphasize that we need to try to get ahead of events, and more data can bring us the opportunity to anticipate relapses or just to identify which patients can be benefit from an optimization and discontinuation of therapy. This can probably be done in the next future. And about how long this question is really difficult to answer, we have been working on the drug retention rate and of adalimumab, that it was more than 50% at 60 months, with concurrent IMT having no influence on this drug retention rate. And there were some factors predictive for discontinuation. So when we were using adalimumab as a second or further biotherapy, this was predictive for discontinuation because of efficacy. And when we were dealing with undifferentiated uveitis, this was predictive for discontinuation because of adverse events. And these results of the drug retention rate were more or less similar than those reported from some other groups. And finally, a summary of my lectures pointed out that there is a lack of solid evidence in the systemic treatment of non-infectious uveitis. The second thing is that our goal should be to preserve function, and this requires to act soon enough. That the decision making in these difficult patients, we need to be structured, to be standardized, and to base on literature and available evidence. This is not always possible, but for those patients in which this is possible, we need to follow this recommendation. And decisions make based on more data, like those regarding serum drug levels, with algorithms incorporating this data, will be more likely successful. So thank you very much for your attention.
Thank you so much for that wonderful talk and wonderful introduction to a really complex topic. Our next speaker is my fearless leader, the person who is the head of the Uveitis section at Wilmar and our fearless fellow. So the dynamic duo of Dr. Israel Mendez and Dr. Jennifer Thorne, with Dr. Mendez sharing a case of where it's a little bit easier to know when to start immunosuppression.
Thank you, Dr. Birkenstock. Let me share my presentation. See my screen?
Yes, perfect.
Yes.
Okay. All right. Thank you. All right. Hello, everyone. So today I'm going to be presenting a case, mild difficulty case, managed with corticosteroids initially, which I titled Red Eye Deeper Roots. I have no financial disclosure. So as part of chief complaint, this is a 14-year-old female that presented to the emergency department with a 1-week history of right eye pain, redness, and light sensitivity. She reports that symptoms have gotten progressively worse and, I don't know, accompanied by blurry vision in that same right eye. She reports the first time this has ever happened to her. She cannot associate its occurrence with any particular activity, and she has denied any trauma, any recent upper respiratory infections, any history of autoimmune disease, or any contact lens wear. Upon additional history gathering, there's no past ocular history, no past medical history, family history is non-contributory, social history, no recent travels outside the US, no IV drug use. She wasn't taking any medications, and the review assistance was completely unremarkable. On initial evaluation, when the patient was seen at the emergency department, the vision had decreased vision in the right eye with J10, pinhole J3, and in the left eye, she was J1. The intraocular pressures were normal at 14 and 12. There was no APD on either eye, yet the pupillary response in the right eye was low, and the confrontational visual fields and extraocular movements were full and orthophoric. So upon initial evaluation, we found a very hot injected right eye. And if you look closely in the picture of the center, there's a thin hypopyon, and there were no ocular secretions. Upon slit line exam, there was reactive ptosis, there was 2 to 3 plus injection, there were active inferior KB without fluorescein uptake in the cornea, 3 to 4 plus cell, 4 plus cell, I should say. There's hypopyon, and there's fibrin collection. There were prominent vessels in the iris, no transillumination defects, and there were posterior synechiae. The view to the back was hazy due to the high degree of inflammation in the anterior chamber. Yet in the fundus examination, all the structures in the back of the eye were structurally normal in the right eye. Similarly, in the left eye, all the structures, including the anterior chamber or anterior segment examination, the posterior pole, were normal. So in terms of clinical formulation, we have a 14-year-old female with acute onset anterior uveitis, the right eye, unilateral, and there was hypopyon at presentation. So we came up with a differential diagnosis for this patient. Top of the list was HLA-B27 associated anterior uveitis, and undifferentiated anterior uveitis, are more atypical patient disease associated anterior uveitis, or even sarcoid associated anterior uveitis. So in order to ascertain any posterior involvement or vasculitis, we perform a wide field FA. Here we have the FA at different sequences of the right eye, and we see there's a normal angiogram of this eye. The left eye as well showed a normal angiogram, so there was no posterior involvement of the uveitis. So given only anterior chamber inflammation was confirmed for this patient, there was no great concern for any infectious process, underlying infectious process. So we started the patient in prednisolone acetate or topical corticosteroids and cycloplegia, and a uveitis workup was ordered. The uveitis workup was negative for syphilis serology, tuberculosis, Lyme, and chest X-ray. but it was positive for HLA-B27 antigen. So given the results of the labs were negative for any underlying infectious process, we started prednisone with the patient, oral prednisone 40 milligrams with a fast taper every 3 days in order to suppress the inflammation faster. We followed the patient 4 weeks after, and now the vision had improved to baseline to 20/25 at distance in 20/20. She was using Pred Forte, the prednisone acetate, 4 times a day in the right eye. She was tapering the prednisone, taking at that moment of evaluation 2.5 milligrams daily. So we have pictures of the patient here that show basically the broken synechiae and the position of pigment in the anterior lens capsule, and much improved. And at this point, the inflammation was suppressed for this patient. So moving forward with this patient, the plan is to continue the topical steroid taper, continue the oral steroid taper until stopping the medication, monitor for inflammation recurrence, and also consider rheumatology evaluation if at any point symptoms of an inflammatory spondyloarthropathy ensue in the case of this patient. So I will now pass the baton to Dr. Thorne, where she's going to expand on HLA-B27 associated uveitis.
Thanks, Israel. Actually, I wanted to point out a couple of things about this case because, I think that a short burst of oral steroids works very nicely in particularly fulminant B27 disease with less secondary macular edema developing. So you're basically putting out the fire faster. And it's probably one of the few cases, if the only case of active uveitis where I will use oral corticosteroids with a taper as fast as possible. John, sorry, my video is not working. My computer is 10 years old and I'm in the process of replacing it. So the camera is dead. However, I think it's important to point out when in the United States, when we see a hypopian uveitis, we kind of lean toward B27 as a presumptive diagnosis, mainly because that is the most common cause or associated condition with a hypopian uveitis, but that's not perhaps the case throughout the world. And I think it's important to think about Behçet's disease. And I was actually hoping that maybe the panel might be able to comment. If you have somebody that presents with an anterior uveitis with hypopian, and you discover that it in fact is a Behçet anterior uveitis, are you moving immediately to immunosuppression with the thinking that you'd like to avoid posterior disease? Or are you treating this acute case, letting it resolve, and then sort of seeing what happens with the patient with Behçet's?
Well, Jennifer, thank you for asking that. You're asking us, this is Quan Wen from Stanford here. So certainly that will also depend on what other findings. So right now, Israel, and you just show mainly the anterior segment with the hypopian. But let's just say if there is also finding the posterior segment with vasculitis, and so if that was the case, then we would probably likely to go directly to a biologic treatment for that, because we know for disease like Adamanitis Behçet disease that steroid alone would most likely not lead to the remission status. So certainly if the disease show more, then it's likely to be the case. Now, if you ask what happened with just hypopian only, like you just show, I think even then still I would probably consider think beyond corticosteroid at the beginning, knowing the disease that is being Behçet.
Thanks, Quan. I appreciate that. I can't recall if Dr. Mendez, I seem to recall that they did a fluorescein on this patient, but Israel, can you confirm for us? You're on mute.
It was shown.
It was shown. Okay. So there was no,
Yeah,
there was no.
I'm sorry, I didn't figure I was mute. Yeah, we did NFA and it was normal, and for both eyes, and it was precisely done to rule out any posterior involvement in Behçet's. Yeah.
Right.
Oh,
So
yeah.
clearly no posterior involvement right now, Kwan. But my curiosity is throughout the world where it may be more common to get Behçet's, do people go ahead and start the immunosuppression before they ever see any posterior involvement, with the idea toward sort of maximally controlling the disease? We don't see enough of this in Baltimore. So we do the FA to make sure that we're not dealing with something else associated with the hypopian, but we're kind of presuming that those labs are going to come back with a positive B27, and then we're not going to have to worry about immunosuppression in this case unless multiple frequent severe flares continue to come up, in which case we may introduce that, or something like ankylosing spondylitis or something systemic that might benefit from immunosuppression. I don't know if anybody else on the panel wants to comment if they are utilizing immunosuppression as a kind of a first strike for Behçet's anterior uveitis.
Well, as you comment, is sometimes it's difficult to go ahead in a patient in which there is only evidence of anterior segment inflammation. But you bring a really difficult disease, which is Behçet's. And I agree with Kwan that in these patients, only one relapse can significate a really structural damage in terms of infarcts, in terms of severe complications. So in this case, I would recommend to a thorough exam of the systemic disease. And I would say that I'm not sure if there is no complication, if there is nothing regarding posterior segment, if I will go ahead with biologics or just stay on classic immunosuppressive medication. But for sure, I will treat with systemic therapy for some time at this patient, even with no more relapses.
Thank you. Okay, so in the interest of time, I'll just make one other comment that I think is very important for your consideration regarding HLA-B27 positive disease, and that is to make sure that you're thinking about these systemic diseases that are associated with B27 and uveitis. There are two wonderful studies, Sentinel and Duo, that are dual, that both showed us that we probably under-realize or underdiagnose the rheumatic component of B27 positive disease among people that have developed uveitis. And so it's important to investigate symptoms of arthritis, low back pain, stiffness, those sorts of things, because in both of those studies, when there was a more systematic approach of doing x-rays and asking for symptoms, there was up to 50% of the patients discovered to either have a spondyloarthritis or an axial arthritis. And so I would just encourage people to keep that in mind because this is a type of arthritis that, when caught early, can be easily treated. And also the long-standing sort of curvature in the spine can be avoided with treatment and physical therapy and exercise. So I'll turn it back over to, I think, Meg for our next case.
That's very important, Jennifer. I think that you raised a very good point before we end, because we definitely have to pay attention and be close to the disease course. Yes, the first case is represented, and definitely we saw the flow scene, but the question was like, if you think with disease like Behçet, then in that case, we need our understanding, and as you point out, our colleague who have much more experience than us, for example, in the US, can also let us know how often do they just say Behçet disease would just only, for example, hypopian only, and would not proceed to posterior segment once they get to that level. So that's really good discussion. Thank you.
Thank you.
Thank you guys for another great case. We're really lucky to have a lot of the greats in the field who were part of a lot of the seminal work in our subspecialty. And so Dr. Kempen is part of our education committee, but was primary investigator in the site study. And he's here to talk about conventional immunosuppressants with a little bit of a more difficult flavor. And presenting the case will be Dr. Emabet Tabor.
So we're happy to have Dr. Emabet, who is the first uveitis specialist in sub-Saharan Africa outside of South Africa, and not a trainee, but fully qualified and very strong now. So it's a big step for Africa. Thank you, Dr. Emabet.
Thank you, John, for the nice introduction, and good morning, good afternoon, and good evening. And I would like to thank IRCG and Professor Kempen for letting me have the chance to present this case. And this is it's not going. So this is a 39-year-old male patient who presented to us on November 14, 2022, with a chief complaint of blurring of vision and floaters on both eyes of 2 months duration. He had also redness of both eyes and also photophobia. On systemic review, he has no history of systemic illness. On physical examination, the visual acuity in the right eye was 636, the left eye was 618, and intraocular pressure was 14 millimeter of mercury on both eyes. And the pertinent finding on his eye, he had class 2 cell and class 2 flare on both eyes in the anterior chamber. He had also class 2 cells in the vitreous in both eyes, edematous disc. There were also small whitish chorioretinal lesions which were located inferiorly on both eyes. With a diagnosis of pan-uveitis, we just investigate him with antibody test for syphilis, which was negative. We did also tuberculin skin test, which was negative. Chest X-ray was normal, and we did OCT examination. So the right eye, he had macular edema with optic nerve edema, as well as vitreous cells. In the left eye, he had vitreous cells and also macular, just optic nerve edema. So we started him with the treatment of dexamethasone eye drop to be applied every 1 hourly on both eyes, atropine 1% just to be applied both eyes twice per day, prednisolone 20 milligram PO daily, and calcium and vitamin D to be taken daily. And we re-evaluated him after 2 weeks, and his vision was the right eye 636, left eye 69, and he had improvement with the cells in the anterior chamber, and it was plus 0.5 on both eyes. And the chorioretinal lesions were gone. And we gradually tapered the frequency of application of the dexamethasone eye drop, and we just kept him finally in once per day as a maintenance dose. And also the prednisolone tablet was gradually tapered to 5 milligram PO per day. And this 5 milligram PO per day and also dexamethasone eye drop once per day was kept as a maintenance dose. And we reevaluated him after 2 weeks, and he had improvement with his vision, with correction. Right eye was 6.9, left eye was 6.6, and there was no sign of inflammation. So the patient had a plan to go abroad for work in somewhere else. So we advised him to continue this 5 milligram PO per day and also the drops 1 per day as a maintenance dose until he see another doctor in the place where he's going to go. That was in the Middle East. So unfortunately, he came back after 3 months with decrease of vision on the right eye. So his vision dropped to 660. With correction, it was 624. The left eye was 618, and with correction, it was 618. He had fine capillaries, and in the anterior chamber, he had class 2 cells on both eyes, and also vitreous cells and snowball. There was a finding on the OCT. He had macular edema with choroidal elevation just between the macula and the disc on the right eye. In the left eye, he had also macular edema. So this was the video of his right eye macular edema with choroidal fault. And we just treated him with high-dose PO prednisolone, 60 milligram PO per day for 1 week, and also prednisolone acetate 1% eye drop to be applied every 1 hourly on both eyes, and also we gave him calcium. So he was re-evaluated after 1 week. His vision, just right eye, it improves with correction to 612. The left eye was improved to 6.9 with correction. And even the inflammation was better. And he had plus 0.5 cell on anterior chamber cell. So we just tapered the PO steroid gradually to keep him on 7.5 milligram PO per day, as well as the eye drop just tapered from more frequent to once per day gradually. So just we kept him in this 7.5 milligram per day prednisolone PO, and also the eye drop, 1 drop once per day as a maintenance dose. And we were able to control the inflammation for 1 year. Then after 1 year, he presented with headache, pain on the left eye. His vision was right eye 612, left eye 6.9, pertinent finding. He had more anterior chamber cell on the left eye, which was +1. And he had hyperemic disc on both eyes with OCT and ultrasound. So he had this lesion, which is choroidal elevation at the macula, as well as supratemporal to the macula. With the ultrasound, B scan, it clearly shows choroidal thickening, which is hyperechoic and diffused with 3.25 millimeter depth. So just at this time, we repeated the PPD test and it was negative. We did also a graph, which was negative, and we workup him in order to start him with immunomodulatory treatment. So we started him with methotrexate 10 milligram once per week, which was gradually increased every week to reach to 20 milligram once per week. And also he was taking folic acid and prednisolone 5 milligram PO per day. So through his course of treatment, this was his OCT on the left eye with clear resolution of this choroidal elevation and this choroidal granuloma. So his recent checkup, that's with after starting the immunomodulatory, it was almost 1 year, and his recent checkup was on May 20, and his vision with correction was 6.6 with no sign of inflammation. Thank you for your attention.
John, if you're speaking, we cannot hear you.
Okay, sorry. Thank you, Dr. Emma Bate, for presenting that case. And it sort of illustrates how we often approach managing disease with just steroids, which we often do in Ethiopia because of cost constraints. And it seems to work pretty well for many patients, but some will need to have immunosuppression if they are breaking through the minimal suppressive dose with topical steroids. So I'm going to talk about the sort of conventional immunosuppression, and then Kwan and his team will talk about biologics. So here are my disclosures. Having difficulty advancing. Okay, there we go. So this is sort of the way I look at the paradigm of treating non-infectious uveitis once you've sort of decided it's non-infectious, to induce with high dose, typically steroids, either topical and oral, to quickly achieve control of the active inflammation, then to gradually reduce the induction dose to see if the disease remits, like the first case from Welmer, and if not, to identify a minimal suppressive dose for suppression, like with our case. And then to continue the suppressive dose then in the chronic cases, using the what I call minimal suppressive dose to have as few side effects as possible, hopefully no side effects, but maintain control of the inflammation. And then maybe someday they might achieve remission, although we don't have a lot of treatments that really cause remission, except maybe alkylating agents. So I mostly then am talking in the suppression area when using immunosuppressive therapy. And sort of what is a safe minimal suppressive dose is sort of not very evidence-based. We've done some work on the incidence of cataract that suggests that 1 drop of predacetate every other day looks pretty safe. 1 drop a day might have a higher risk of cataract. 2 drops definitely does. And also 1 drop a day of topical steroid has a higher risk of like almost double of elevated intraocular pressure. Um, Prednisolone 7.5 milligrams per day, or preferably 5 per day, seems to be fairly well tolerated based on MUST data. And so we're sort of hoping to get in that range. And I suspect we'll be wanting to get better than that as our immunosuppressants become better and more available. But often we need to have help from an immunosuppressive drug for steroid sparing. So this is a fairly old paper now, about 25 years old, and some of it's getting dated, but it still has a lot of good information about how to manage the conventional immunosuppressants. So I would recommend it, and I'm going to talk about some of the principles from it. So there are 3 major indications, at least the way I look at it, for using immunosuppressive therapy. So one is if the sort of safe suppressive dose of corticosteroids is not enough, then we would use it for corticosteroid sparing, and that's the main indication. There's a rare patient who, if corticosteroid therapy fails to control the inflammation, we might go on to immunosuppression, and you should very carefully reconsider the possibility it could be infectious if you encounter that situation, because corticosteroids are really the strongest in inducing control of inflammation. And then some specific diseases that many people think should be treated initially with immunosuppression or very early because they're very likely to need it. And that's sort of an ever expanding area. But Behçet's disease with posterior uveitis, like we were discussing earlier, birdshot, the serpiginous, but not make sure it's not associated with tuberculosis, necrotizing scleritis, which is associated with higher mortality from systemic vasculitis, typically, and pemphigoid with cicatrizing conjunctivitis, and arguably others, and probably more and more as we go on with more confidence in using immunosuppressive drugs in terms of the safety and the options that are become more and more beneficial. So we sort of talked about in the Miguel's thematic lecture about the specific drugs. So I won't spend much time on this, but we use antimetabolites, T cell inhibitors or calcineurin inhibitors, basically cyclosporin and tacrolimus or tacrolimus. The antimetabolites are relatively contraindicated in liver disease, and the calcineurin inhibitors are relatively contraindicated in renal disease and hypertension, and also with age of 55 years or more that we found in sight had triple the chance of stopping the drug. And then alkylating agents we'll talk more about shortly. And this is a summary slide that Doug Jabs made for the MUST group, sort of based on this initial paper. And I think, though, that we've been sort of wanting to go towards the top of the range in more recent years for maybe not for the alkylators, but for the other drugs, sort of as much as tolerated and then scale back. And so you saw in our case that we use 20 milligrams. It seems like we have a lot of complaints about methotrexate. I'm not sure why. It seems like it's more than when I was in Philadelphia, so we were sticking with 20, but like the FAST trial used 25. So anyway, you might want to just take a photo of this one because I can't spend too long talking about it. So which one should we use? So the FAST trial that was Nisha Acharya was the PI of, she sort of did some questionnaire of the American Uveitis Society, and methotrexate and mycophenolate were sort of the 2 most popular drugs. And so she and her colleagues from all over the world compared methotrexate and mycophenolate in a randomized clinical trial, and methotrexate was proven to be non-inferior, and a few more words about that later. It's also cheaper than mycophenolate. Azathioprine hasn't really been compared, other than we looked at it with site, and it's popular in less developed countries and also reasonably inexpensive. So methotrexate and azathioprine are the inexpensive ones. And in sight, all the antimetabolites were similar. The methotrexate was just a hair better, but it's not statistically different. And cyclosporin tended to do less well, although I suspect that that might be because it was especially used by the National Eye Institute site. And I think since every single visit was like part of a protocol, that they might have been more aggressive about documenting 0.5 plus cells, because if you counted 0.5 plus cells as a success, they did better. Many would argue that you should combine a calcineurin inhibitor with an antimetabolite if you're going to use combination therapy, but this is sort of becoming less popular with biologics available. So this is sort of the summary of the primary results of the FAST trial and the reference if you want to look it up. But note that the odds ratio for success by 6 months was considerably, there were 50% higher odds of success with methotrexate. However, the confidence interval covered one and it wasn't statistically significant, so it could have been observed by chance. But it did formally prove that methotrexate was non-inferior. And so moving on then to alkylating agents, these are arguably the only ones that cause remission of disease, and up to 2/3 of those tolerating therapy, although a lot of people don't tolerate therapy based on site. And in site, it was a little bit less than this. This was, I think, mostly coming from pemphigoid series, but there are a lot of remissions with these. And there's a short-term high-dose approach with chlorambucil that's been used almost exclusively in Chicago that looks promising, but we've kind of mostly been afraid to use it, and where they kind of escalate the dose pretty quickly and then just stop it once the patient sort of begins to become aplastic from it, and then they often seem to remit after that. The use of alkylators is limited because there's a high incident of sterility, as much as half, especially as women get older, and also affecting men potentially. And it requires weekly monitoring for some time. And there's possibly an increased risk of cancer, at least of certain types. In the site studies, we haven't really shown that, or at least not to a degree that could be detected. And so because of the potential side effects, it's less popular. So in our case, then, at first it wasn't clear that immunosuppression was needed. It was looking like with low-dose topical and oral steroids, we would succeed in managing it. It was a pan-uveitis, so we needed to give more than topical therapy. But over time, severity increased, and it became clear that we would need to give something. So we view methotrexate as the first-line antimetabolite based on the FAST study and the cost, and it's available in Ethiopia, and that ultimately worked. So when we follow such a case, we'll need to follow it for tolerance through symptom query and monitoring for toxicity from lab tests. And then if the initial drug fails, we can either try another or we can advance to biologics, which Quan will tell us about. And we're not really seeing, as far as I can tell, just sort of without formally studying it, an increase in infections in Ethiopia with methotrexate and azathioprine. But I think we might, if we have the privilege of using TNF inhibitors more, because like 1 out of 3 has gotten disseminated tuberculosis. I'd like to point out something that we saw a lot in site, although I'm showing from the FAST trial, that it takes a long time for these conventional agents to work. So you can see some people would say it should work within 6 weeks. So that would be right about here. And you can see almost none of them were successful by then. Maybe there would have been more because there's only certain visits in this trial, but you can see you're really getting out to 4 months before you have 50% success. And so you really need to give time for this. And then 6 months was what they had chosen for their primary outcome. So 4 to 6 months is probably you need to sort of spend time waiting to see if it's going to work. And you're going to have to deal with the uveitis during that time, which might require high doses of oral steroids. So it's sort of a difficult thing and probably will tend to drive us towards TNF inhibitors, which a recent site publication suggests are faster in the onset of achieving treatment success, especially if like it was only formally shown if it was combined with methotrexate as well. But TNF inhibitors appear sort of, according to our impression, to be faster, and are faster based on these data. Unfortunately, the ADVISE study, which is about to be reported, isn't reported yet, so we can't cover that today, but in the next 1 to 3 months, it should be reported. So what do you do when you want to go on immunosuppression or conventional immunosuppression? So you should look at some initial laboratory testing for potential contraindications. So for antimetabolites, I check for hepatitis B and C. We would want to check about hypertension or renal disease with cyclosporin and tacrolimus. We want to address if pregnancy could be present. And for azathioprine, we would like to look at thiopurine methyltransferase, especially to see if they have homozygous deficiency, in which case they can become aplastic very quickly. Unfortunately, this test is not widely available worldwide, but it's nice to be able to check that. And then we do baseline testing for liver enzymes and CBC. So regarding pregnancy, there's just published, I think it's sort of published before print. So you might want to take this one down with the PubMed ID number, which is a very nice review by the European League Against Rheumatism. They have a new name now, but about pregnancy and reproduction and immunosuppressive therapy, because many of our patients are reproductive age women, especially if we're looking at intermediate posterior and panuveitis. It seems like about 60 to 65% will be women. And so if we're going to go on immunosuppressive therapy, we need to encourage avoidance of pregnancy, such as through contraception or complete abstinence. And this is because the FDA and probably the European labels also warn against using immunosuppressive therapy in pregnancy. Now, some agents like methotrexate, mycophenolate, and alkylators are frankly contraindicated. Like methotrexate has been used off-label for abortion, and so it causes fetal loss and a high risk of problems. And even males have been advised to wait 3 months after stopping before impregnating their partner. Although there's some newer data that it seems like with this, they weren't quite ready to loosen that statement, but it looked better than what had been thought. Cyclosporin and tacrolimus haven't been associated with excess malformations. Tacrolimus does have a warning in the FDA label, but cyclosporin, the warning surrounds more like immunodeficiency. And there was a nice transplant study registry that showed no excess malformations. With azathioprine, it's also not been found to be associated with malformations or adverse pregnancy outcomes, although the label warns against its use in pregnancy. So these would be kind of the best options if the person had to be pregnant and were needing therapy more than steroids. Corticosteroids have traditionally been thought to be the safe approach during pregnancy, but there is some suggestion that there's a higher risk of preterm birth at doses such as we often use, even in the 5 to 10 milligram range, as well as some suggestion of a higher risk of maternal infection. There's a placental enzyme that protects the fetus against the effect of the drug for the most part. All JAK inhibitors also should be avoided, although the basis for that is because there aren't sufficient data to evaluate it. And there was some concern about reproductive issues in men, although in the filgotinib trial that was done, it didn't come up, or there was no signal. Other drugs thought to be safe but aren't used often for uveitis in pregnancy include sulfasalazine, hydroxychloroquine, colchicine, and IVIG. And I'll just mention TNF appears to be largely safe. There were more malformations in crude analyses, but after adjusting for severity and other factors, it's not shown, although it's a little bit more than one. So this is thought to probably be safe, and Kwan may or may not be talking more about that. Another drug thought to affect male fertility is sulfasalazine, which is reversible. It's more like you would be less likely to have conception. Okay, getting back then to longitudinal follow-up of these patients. At each visit, we want to query them for symptoms that might result from the treatment, although we don't want to be too aggressive about doing that and sort of encourage them to complain about minor things. It's ideal to follow weight if they're continuing oral steroids and if children are being managed with oral steroids over time, which isn't recommended in most cases, though we have to do it sometimes in Ethiopia due to our resource restrictions. We would want to monitor height as well. And then we want to do follow-up testing for liver enzymes and complete blood count and for magnesium for calcineurin inhibitors. The guidelines paper gives a very detailed approach that's different for every drug, but I prefer to just do it baseline 1 month, maybe 1 month again, and then quarterly after that, and then maybe going to semi-annually if nothing's happened for more than a year. Once a successful minimal suppressive regimen is established, we should continue that for a long time. We don't have very much detail about the remission of uveitis, only with intermediate uveitis and chronic anterior uveitis, but the remission rate is not high, neither for anterior scleritis. And so we probably want to continue at least 2 years, and we may have to carry out dose adjustments like down, if we start with a higher end dose, we may need to reduce the dose in some patients or switch agents if they just don't tolerate it. During maintenance therapy, you may have occasional flare-ups related to some sort of immune stimulation, and you may not need to change the minimal suppressive dose if that happens. But if it happens multiply, then you do need to revise it and sort of scale up. And we would treat a major flare-up with reinduction with steroids and sort of a smaller flare-up with a partial reinduction. My mentor always said double the dose. So MUST, I think, arguably establishes systemic therapy as first line for maintenance therapy for posterior involving uveitis because it was non-inferior or by 7 years possibly superior to long-acting intraocular implant, and cost is lower. And with FAST, I think it pretty well establishes methotrexate as first line unless you sort of love azathioprine. And the systemic approach does provide good visual outcomes, although it requires a lot of difficulty. In MUST, we saw that the vision was preserved on average for the whole 7 years of follow-up. And in SIGHT, we saw a tendency for initial improvement probably from the induction, and then stability to improvement in most IUSG categories of uveitis over time. So I think I'm talking too long, so I'm going to just briefly say, is systemic immunosuppression safe? So the SIGHT study that looked at the long-term incidence of death and of cancer made a quite persuasive argument through about up to 10 years of median follow-up that methotrexate, azathioprine, mycophenolate, cyclosporin, and TNF inhibitors are safe with respect to both death and cancer. And MUST argues pretty well for the short-term safety. And so I'll leave you to look those up, except I'll just mention the MUST one, that we didn't really see a lot of side effects in the prospective follow-up there, especially for the immunosuppressive drugs, which were very similar in the proportion, and really the only one that looked somewhat different, though not significant, was actually higher in the implant arm. I should say, too, that we did see more infections requiring treatment with the systemic arm, but I think that might be due to a sort of, treatment bias. So overall, then, wrapping up, we want to choose the treatment that works and avoids complications as much as possible. We want to manage complications if there's no better option, or if the complication is reversible, like we might do occasionally with cataract, especially if it's already getting going. And we might need to treat macular edema with additional therapy based on our observations in MUST, and we have to be patient with the conventional immunosuppressive drugs. So in summary, immunosuppression is first line, probably, when criteria for immunosuppressive therapy are met, and methotrexate is probably the first choice worldwide. The main indication is that it's safer than using high-dose oral steroids, not because it works better. And with monitoring and dose adjustment, it does well, but it does require a level of skill and attention and cooperation by the patient. We have to be careful in our consideration of pregnancy, as well as sort of other side effects that come up for individual patients. And it's slow, so we have to be patient, but it has good visual acuity results. And now we have more options available if the first line doesn't work, which we'll hear about next. Thank you very much.
We're having a lot of really great talks this morning. Thank you, Dr. Kempen. And our final talks will come from our group from Stanford. So Professor Quan Nguyen and Dr. Jia Hung will be presenting the case for them this morning. Thank you for joining us so early from California.
He's snoring, that's okay.
Okay, please let me share my screen. Yes. Okay. Good morning, good evening, and good afternoon for everyone. It's my honor to be invited to speak in the IUSG Uveitis Grand Round. And my case is a recurrent vision loss in a teenager with contraindications to oral corticosteroids. I have no financial disclosure. This is a 16-year-old female who complained decreased vision, left eye more than right eye for 2 weeks with flashes. The visual acuity is 20/30 in both eyes. C-lab examination is remarkable for 1+ cells in the anterior vitreous. Here is the fundus. As we can see here, the disc margin is clear, but there is macular hemorrhages at the temporal side of the macula, as well as infiltration along the blood vessels, and there are also multiple retinal infiltrations in the peripheral retina associated with retinal hemorrhages. The left eye is even more prominent, as we could see more infiltration along the blood vessels. Fundus autofluorescence shows hyper and hypoautofluorescence along the areas. Fluorescent angiography confirmed block effect of the retinal hemorrhages, and also a capillary non-perfusion area in the periphery with leakage in the peripheral blood vessels. OCT shows there are outer retinal damage and thinning and loss of the structural lamination, as well as epiretinal membrane and subretinal fluid in the right eye. And the left eye shows that there are temporal retinal thinning and also a mild shallow subretinal fluid in the central fovea. So what is the diagnosis in this young girl? We are considering infectious etiology like CMV retinitis is on the top of the list, and also inflammatory one like adenoiditis, Behçet disease, and others including malignancy. So let's trace back her history. The ocular history is unremarkable except for astigmatism and hyperopia. And regarding the medical history, this patient has acute T-cell lymphoblastic leukemia on chemotherapy for 6 months, including the time when she presented to our clinic. And she also had a history of systemic steroids-related bilateral hip osteonecrosis. And the laboratory workup shows that she had leukopenia and very, very low CD4 count. Other than that, she's normal for other immunology examination. She is also negative for HLA-B27, B51, and A29. Other infectious workup, including quantiferon, syphilis, HIV, and toxo, are negative. Additional examination shows she had positive plasma CMV IgG and IgM, and also CMV DNA is positive. So we performed AC-TAP and intravitreal phosphokinase, and the result came out to be positive for CMV DNA. Therefore, the patient's diagnosis is CMV retinitis. We started the patients with intravitreal phosphokinase injections in both eyes. 2 times, the second time is 3 days after the first one. And we also started the patients on intravenous ganciclovir and then tapered down to oral valganciclovir. After the treatment, 2 weeks after, we could see there are decreased infiltration along the blood vessels and the absence of subretinal fluid in the right eye and also in the left eye. And after 6 weeks, we could see those retinal infiltrations are almost gone, and the peripheral infiltration now shows some scarring. At the 10th weeks, we could see there are some scarring in the peripheral, And other than that, we could not easily detect the retinal vessels infiltration. However, 3 months later, the patients complained the blurry vision in the left eye again for the last week before she presented to our clinic again. At that time, she already discontinued valganciclovir, and she also discontinued the chemotherapy because of the completion of the course. Her visual acuity of the right eye is 20/20 and the left eye is 20/30. And examination shows 0.5 plus cells in the anterior vitreous. At this time, this is the fundus imaging. We could see that it is quite different from the previous fundus examination. In the right eye, there is no retinal vessels diffuse infiltration like that last one, but you could see some scarring at the previous retinal infiltration in the periphery. And in the left eye, we could see there are some maculopathy and also peripheral scarring. A close-up look shows that there are multiple fluid pockets at the temporal side of the macula. Fluorescein angiography is also very different from the previous FA. We could see this time she had disc hypofluorescence and non-specific capillary leakage in the peripheral retina. Also, there are macular hyperfluorescence and capillary non-perfusion in the periphery. OCT exam shows there are intraretinal fluid in both eyes, and left eye also had subretinal fluid. Laboratory shows the white count has actually returned back to normal, and the CD4 count also increased a lot to the normal range. And in the plasma, there is no CMV DNA. And what is the diagnosis this time? Could it be active CMV retinitis? Or could it be immune recovery uveitis? Or could it be masquerading syndrome? That means our previous diagnosis probably is not correct. So we think that the patient actually has an immune recovery uveitis, given the fact that there is a dramatic increase in the CD4 count and based on the history of her medication usage. At this time, while we are making a treatment plan, we have to consider all of her systemic condition. Therefore, we continue and restarted valganciclovir. The systemic steroids are usually the gold standard treatment for IRU. However, because this patient has a history of osteonecrosis, this became a contraindication. Therefore, we would rather choose biologics, either TNF inhibitors or IL-6 inhibitors. Then we started the patient with IV methylprednisolone for 2 months, then discontinued with oral taper. And then we started the patients on tocilizumab 8 milligram per kg monthly. As we can see, after 3 cycles of tocilizumab, there are marked decrease of the leakage in the periphery, and there is absence of subretinal fluid in the right eye. And the left eye also shows improvement of leakage. After 7 cycles of the tocilizumab infusion, the visual acuity remains stable in the right eye, and there is less leakage in the periphery. And also in the left eye, we could see that the leakage also improved greatly, and the visual acuity improved to 20/20. Discussion. Immune recovery uveitis has been reported in patients with AIDS after heart therapy. However, nowadays we could see that there are more and more immune recovery uveitis seen in non-HIV infected patients. IRU used to be a complication of CMV retinitis, and it is still commonly in AIDS and CMV retinitis after heart treatment. The risk factor of IRU is increasing CD4 count to a level more than 100 cells per microliter or decreasing HIV load. As previously stated, the treatment for CME associated with IRU, the first line is corticosteroid therapy, including topical or local or systemic. And in the literature, intravitreal aflibercept has been attempted. And the third one is IL-6 inhibition. The rationale of use supporting IL-6 inhibition in UME secondary to non-infectious uveitis rooted from the STOP Uveitis study conducted by Dr. Yasir Sipa. In the STOP Uveitis study, we could see that after tocilizumab treatment, there is a significant reduction of the cystoid macular edema at month 6. Therefore, systemic IL-6 inhibition can treat UME. And take-home messages. In our case, the CMV retinitis can occur in patients with immune deficiency. IRU arise after the recovery of the immune system, especially when CD4 counts return to normal. IL-6 receptor antagonists such as tocilizumab could be a therapeutic approach for IRU. And this study has been published recently in the Yale Journal of Biomedicine. Thank you very much. With that, I would like to thank my mentor and all of our collaborators.
Thank you, Dr. Hunt. Dr. Hunt will be shortly joining our uveitis faculty at the Bio Institute at Stanford. So we're looking forward to have his contribution to future aspect. I suspect if there's any question from the case, please let us know. Certainly, this case illustrates several points. First is also, this is the 25th anniversary year that I and John Kempen published one of the first paper in immune recovery uveitis IRU. So looking back on the last 25 years, what we have learned, and certainly of that aspect from there. This case illustrates several different points, as you can tell there. The diagnosis of CMV retinitis was not so difficult. And even the diagnosis of IRU was certainly very straightforward. It was not the challenge. The challenge was then what to do with this particular patient and what kind of management do we have. Gia went through the different thinking in our process here. This particular patient have a very, very, in a way, contraindication, absolute contraindication to oral corticosteroid because of the already history of necrosis. So the medical team was really against any type of using of systemic therapy for that. Now, in our initial work with IRU, John and I and Doug Jab, we also published that they're using, for example, local injection with steroid, but that is not really appropriate for this patient also because of her very young age. So the treatment of that, using that with the potential problem for intraocular hypertension as well as cataract, was not favorable for that aspect. So that's the reason why local therapy was not chosen. In addition, beyond the fact that the parent did not want to do anything with steroid. So we left with behind the choice of what else to do with this particular patient here, what type of treatment that we can use. John went over, Dr. Kempen went over some of the immunomodulatory therapy, the IMT, but as we know from the literature, the use of mycophenolate, methotrexate, cyclosporin, none of them really have very strong, good record of treating macular edema, especially uveitic macular edema. They may help in some cases, but certainly not helpful to that level. So then we have to left with what to do in this particular case where there's significant macular edema and how to manage it. And then therefore, yes?
Sorry, there's a couple of people saying they're not hearing you well, so maybe you can get a little closer to the microphone or something?
How about now? Is that better now or no?
I
I
think
can hear you
so.
really well. I can hear you
Yeah,
really well.
yeah.
Sorry about that. So I was thinking again, the case here, the situation here was what to do in a patient who had absolute contraindication to corticosteroid systemically, and who at the age of the patient, young age of that, is not really a good candidate for the use of local therapy with steroid either. So we left with what else to do. And I just meant that you, Dr. Kempen, just indicate to us, showed us some of the use of immunomodulatory therapy, but as we know through the literature, therapies such as mycophenolate, methotrexate, or cyclosporin, none of them really have a good benefit toward macular edema. Actually, it's nothing consistent at all. So that's why we could not really consider them, especially in the acute case. So therefore, Dr. Hung and I, we were thinking, and our team were thinking, what else we can approach here, and what other aspect we can do from that, from the go in there. So we look at beyond that. We look at the biologic thing. And as we know, right now in the field of ocular inflammation and uveitis, the only biologics that has been approved is adalimumab through the visual program, Visual 1, Visual 2, and Visual 3, that have demonstrated the benefit of that. However, when we look carefully at those papers and the number of patients, and also now in our daily practice, we know that we learned that adalimumab can help a little bit with macular edema, but does not have a very strong role in that. In other words, we usually don't see immediate improvement with that. What about infliximab, the other TNF inhibitor? So we, as well as many, also use intravenous infliximab as well in our management. But again, infliximab is doing great in terms of perivascular leakage. It can do quite well. But in terms of macular edema, at least we do not have much great experience with it. So therefore, we're looking for other aspects. And that's when we decide on tocilizumab based on what Gia mentioned, the Stop Uveitis study and other study coming out from Spain and France also show the role of IL-6 inhibitor in managing uveitic macular edema, and it's done a great way to that aspects from there. And as some of you may know, in the last few years, intravitreal interleukin-6 inhibitor in the form of vamikibart has already been investigated for the role of uveitic/inflammatory macular edema, and the result will be reviewed this summer in July at the American Society of Retina Specialists, when we will be looking carefully at the outcome of the MEERKAT and the SENCAT trial, looking at the interleukin-6 inhibitor locally for that. But certainly systemic therapy has also showed significant benefit as well. And given the relatively acceptable safety profile of interleukin-6 inhibitor, that's the reason why it was chosen. And GM showed to you there is definitely showed remarkable improvement with this aspect from there. So here we use a case to illustrate how we use biologic in a very difficult case of management because of not so much of the diagnosis, but because of this particular patient intolerance or contraindicated to other medications. What about other biologics? So I mentioned the only biologic that's been approved in the field of uveitis and ocular inflammation is adalimumab. We at uveitis specialists often employ other agents that we use off-label. For example, we have been using interleukin-17 inhibitor. We have using interleukin-11/23 inhibitor. We also have been using Janus kinase inhibitor for this aspect. So Janus kinase inhibitor, right now we have one of the common one that being used in clinic is tofacitinib. However, that one doesn't really show that much improvement with ocular inflammation. So we're not very keen on that. However, looking at the literature, we learned from the Humboldt study that there's a JAK inhibitor called filgotinib. Through the Humboldt study, showed significant ability in controlling the inflammation as well as the macular edema and uveitis. But unfortunately, that trial was terminated because of business reasons, so we couldn't learn any further. But fortunately, since then, many of you may know, we also have other trial ongoing right now looking at another JAK inhibitor, pepaxtinib, which is a JAK1 tyrosine kinase 2 inhibitor. And for that one, we had the phase 2 Neptune study, which showed quite promising result. And currently, the phase 3 Clarity trial is ongoing in the United States, Europe, South America, and Asia. So hopefully, in the near future, we will have perhaps through the phase 3 study, we perhaps may have another potential biologic that can be beneficial for us. But certainly now for today's theme aspect from there, many of you have already seen, starting with the group from Wilmer, actually from the lecture by Dr. Miguel to show us how we can consider therapy, the treatment like that. And then we have our cases from Wilmer would illustrate the clearly important role of corticosteroid in the initial management. And then Dr. John Campbell and this team from Africa demonstrate to us that we can consider other things besides corticosteroid. In that case, methotrexate was used. And then we, our team from Stanford, just showed to you what we can do beyond corticosteroid, beyond the traditional immunomodulatory therapy agent, just like methotrexate and mycophenolate, when we go to biologics and choosing a case here that show the appropriateness of use. And again, using an agent that we can consider off-label, but certainly have significant data to that. So we in the field of uveitis have been known to always employ therapy that seem to work well for our patient. And then we can also wait for the clinical trial to be shown later, or at time we just continue to use it as long as the benefit can be demonstrated to our patient. With that, I'll stop. And the question for me or for Gia, please do so.
Good. Well, thank you very much, Quan and Gia, and all the speakers. And we're running a little bit late, but we can perhaps go through a few questions. Let me just add too, the biologics such as, especially TNF inhibitors and tocilizumab seem to be something really good for many cases of non-infectious uveitis. And they're, I think, second line, except for Behçet's disease involving the posterior segment. But the main reason for them being second line is that they're very expensive. So if it was, equal cost, they might become first line. We're about to have this ADVISE trial result come out, which I'm no longer involved with, but was involved for the first half. And so I can't report to you the result, but it's comparing adalimumab to sort of conventional immunosuppressants, quote unquote, dealer's choice, as Doug Japps likes to say. And so if that one turns out positive, that adalimumab is doing better, it will probably tend to move a little bit more towards using TNF inhibitors earlier, sort of in the same kind of theme as what I was saying for the conventional immunosuppressants. And like Quan pointed out very clearly, if there's macular edema or sort of subretinal fluid, the IL-6 inhibitor looks really good. Interferons also have been reported to be quite good for that, although causing a lot of side effects in terms, short-term side effects. And those are sort of becoming less available, unfortunately. So, so anyway, we're kind of adding a lot to our repertoire, and Quan has been very involved in a lot of the pioneering of that. So anyway, I imagine you're involved in the studies you mentioned for the new drugs as well. So thanks for all your work on that. So we probably have time for just minimal questions, and Quan and Gia, I wonder if you can try to look at the let's see, there's one well, let's see, maybe we can start with that question from Dr. Mazumdar. What is the safest biologic for TB endemic countries where it may be risky to use adalimumab or maybe TNF inhibitors in general? So what does the panel think about that?
I certainly can start with this. So by the way, can you hear me really well, or I'm still not halfway? John, can you hear? You can hear.
Yes.
So
Yeah. Yes.
So certainly, in the cases of patients in the country like that, we should always take precaution, and it's very important that the patient being tested thoroughly to make sure that he or she does not have any potential TB or even latent TB. And I have to say that in such country, I believe that the safest way to do is, if you think that the patient has TB or even have risk access to TB, and if discussion with the ID specialist, the patient should probably be treated ahead of time, or at least in conjunction while biologics is being used. That would give you much more freedom and much more option to treat with that. So you feel like safe that you have covered that area, and there was never a question of reactivation of TB. And then your question is about what the safest biologic with this aspect from there. So certainly, in literature we have seen so far, the TNF inhibitor may not be the best option there. So in that case, so far, we are, I would suggest that interleukin-6 inhibitor seem to be doing well, given what been some of the cases aspect from there. But again, making sure that you already have that patient treated with that, with a anti-TB already before you begin any of this concept.
Yeah, I would like to emphasize that there is no immunosuppressive safe if you don't do a chemoprophylaxis in those patients with latent TB. So I don't think it's a good idea to talk about what is the safest, but about that you have to do it properly before checking if there is a latent TB, and then do a proper chemoprophylaxis as Kwan suggests, because if not, you are going to have problems even with steroids. So this is I think the step ladder algorithm in these kind of countries.
So we have Rima with us. I don't know what you might be able to add to this, Rima, since you are at a very advanced center that's in an area with a lot of tuberculosis. So maybe Rima stepped away for a minute. We've, it's absolutely required to rule out TB before starting TNF inhibitors. And the case that I alluded to was one that we had ruled out TB, I think even multiple tests, and apparently acquired TB while taking the TNF inhibitor rather quickly after starting it, which was disappointing, because it's a huge, huge cost for the Ethiopian patients to pay for that out of pocket. And so I think it's going to naturally tend to be used less because of the resource limitation, but, maybe we'll sort of hang on to conventional therapy a little bit more in that kind of scenario. Yeah. Okay, well, I mentioned in my talk about pregnancy concerns about immunosuppressants. Like, to me, the data seem to support using azathioprine or cyclosporin rather than systemic steroids, but it's kind of difficult to do that when, the label, especially for azathioprine, is specifically telling you not to. But maybe cyclosporin could be considered in that kind of situation, but I'm curious what other people think or how you've gotten around that. I've historically mostly gotten around it by using oral steroids.
Well, I think for cases that's sensitive like this, first and foremost, before you start them on that for the pregnancy, at least for us, we always get a formal high-risk OB consult. I always send the patient there to get them, because we want to make sure that the latest literature, the latest knowledge is being presented to the patient, because those are the people in high-risk OB. They're the one who follow the patient the closest to that step. So I always ask for recommendation. And even though I, like John, may say that perhaps azathioprine may be reasonable, safe in literature, but again, we don't have all the items, so why don't you attend additional thought from that? And so we always get that. And a lot of the time, it comes back that it's fine. The patient could go ahead and use azathioprine with that as well. Lately, we also have a new, well, it's not a new drug, but a new class of drug that's being used right now called melanocortin in the form of corticotropin. And so the trade name for that is Actar. So a lot of the time, they also recommend that particular can be used in patient with that need to be have inflammation control as well. But again, this is a sensitive question and field, so it's certainly outside of us as ophthalmologists to know this completely. So I always think that it may be best when we do this in consultation with another service which have a lot more knowledge to us. So at least we put all the thinking that we know at any time toward this type of patient.
Good. There was a follow-up question about how quickly you could start a TNF inhibitor after treating latent TB, or possibly it could be addressed even, TB proper. Does anyone have any feedback among the panel for that?
So at least for us from Stanford, the ID group would indicate to us that once they start the ATT, and they usually ask us to wait for about 6 weeks, and they say at that moment, you can go ahead and you can start with that. Obviously, with continuous ATT, maintain that. But because in particular for a TNF inhibitor, for a regular one, we can, let's say the patient have active TB, we say an ocular TB, and let's say some chest X-ray. Sometimes we begin the ATT, and then shortly after that, within a week or so, we begin corticosteroid. But because of the anti-TNF is so potent in reactivation, I would say that we'd be more conservative, and so I would say that 4 to 6 weeks after that, that would be appropriate, because we want to make sure, obviously, for the safety of the patient.
Yeah, I don't think I would be too enthusiastic about using a TNF inhibitor in someone that had TB proper, but maybe latent TB could be considered. So, all right. Well, we've gone kind of long, and probably we should wrap up now unless any of the panel members have other questions to ask. Good. All right. Rima, did you have anything to say about the use of TNF inhibitors in a high endemic area? Since you must have been.
Yeah, we use it with a lot of caution because, the risk of exaggerating the TB is very high. So we basically work them up with all the TB tests and then go ahead. And always with the rheumatologist, starting it, supervising it, monitoring it.
Okay.
Rima, for the last question that John just, I wasn't sure if you hear, because it would be great to hear your advice too. The question was, after you start, let's say ATT, how soon, let's say our colleague in India will feel comfortable starting anti-TNF? In other words, let's say you start ATT with 4 drugs. How long do you wait before you feel comfortable begin anti-TNF in a patient who may need the anti-TNF?
I think considering anti-TNF in a patient of TB uveitis, especially somebody who's received ATT, it's a big dilemma. So I'm not sure if we really would ask a rheumatologist to give anti-TNF to these patients. I would rather go for a local therapy like Ozurdex that works better rather than giving an anti-TNF. If I have a choice, I would rather go for local therapy in these patients.
Yes, and the work from Professor Amol Gupta from India has shown that the group from India colleague, yet you do feel very comfortable. You use like Dr. Benzo just mentioned, you use like intraocular Ozurdex, right? And then sometimes you do quite often, and then while you're doing that, so you would prefer to go with that rather than in it.
Good. Megan, were you going to announce the next grand rounds? Or was that you, Rima? Yeah.
I can start, yeah. So thank you. Before Megan winds up this webinar, I would like to invite you, Team Global, can we have the flyer for the next grand round? So our next grand round, we take summer break. We take and all of you take. So we meet again in September for the 17th grand round on 13th of September. Continuing with the same theme as today's grand round. So that will be on local therapy. And again, we are privileged to have it, would be having Dr. Kwan as the thematic lecturer, who's kindly agreed to do so. With his vast experience, Dr. Jia, who would be talking on suprachoroidal injections, Megan and Mark D. Smet as the discussants for local therapy cases. So, Team Global, can we please have the flyer? Okay, so meanwhile, Megan, you can wind up.
Thank you everyone for joining us. We really appreciate you, whatever time of day that you were able to come. We look forward to your presence again when we start up again in the fall. And again, thanks for joining.
Go back to
And
sleep.
Megan and Rima, could you stay on a
Oh,
little bit? Yeah.
thank you, everyone. Good night. Good
Thank
morning.
you.
Thank you.
Thank you for joining.
Thank you
Thank
very
you.
much.
Thank you.
Bye.
Thank you
Thank you,
all.
Miguel.
Thank you very much.
Goodbye.
Bye.
Thank you.
So I was just thinking we should talk about, do we want to go right into a like starting in November, doing something new? You probably saw that Vishali had suggested doing grand rounds every 2 months. And then I sort of said, well, every month makes it easier for people to keep it on their calendar. And she sort of agreed to that. We were also just before we started today talking about how early it was in California. And in the past, I've thought about doing like one for the Eastern Hemisphere and one for the Western Hemisphere. And, or I suppose the same one could be repeated twice, but that's a little bit arduous. So I was just curious what you thought and how we should proceed with that. Do we want to start in November or do we want a little break? We will have a break this summer. And do you like the idea of institution-based grand rounds without a specified theme?
Yeah,
Which
so institution theme, I don't know, because institution-based is a fantastic idea. But I have a feeling that when we invite the institutions, they would want some kind of theme or an outline, or something like the email has to be something specific. Because if we invite them for any interesting cases or challenging cases, it's very confusing. Suppose somebody invites us, so maybe we can have some theme or maybe not. But institution based is a good idea because that will show how, the infectious cases are managed in a particular area and non-infectious cases are managed, and what is the spectrum, what they see. Um, yeah,
yeah,
I agree.
maybe we let them pick the theme, because they know sort of what they have that's interesting.
Yeah. Theme could be their choice.
Yeah.
I
I'm
agree.
not sure, just really quickly, I keep looking down it and there's still 68 participants. So I don't know if they, just so like we could, I mean, I don't think anybody really cares what we're talking about, but maybe if the person running the webinar could end it for all the,
Yeah.
yeah,
Okay,
and then just leave us on maybe.
sure.
I'm not sure if
Yeah.
anybody from Global
Akshay, Team
Conferences.
Global.
Yes, ma'am.
Can you turn off or end the meeting, but leave us on?
Akshay, can we have the webinar offline?
Okay.
Oh, we're down to 59 participants, so that's good.
I'm not sure if that will go away when we finish, but I don't know.
Yeah.
We can, Akshay, we can have the webinar offline now. I mean, we can not be
Okay.
live. So I'm still live. Maybe we can exit and then chat on the.
Okay. Yeah,
Yeah.
maybe we can just text. So, all right. Well, good. Good to see you both. And a good session again. And I guess we have two more. Were we going to include this session in the book? I think maybe
Yeah,
we were. What's that?
yeah, through October. So September and October will be the last two. And I'm halfway through last month in May. And then now I have this one to do. So I'm getting there. January and March are done. April is sent out to everybody who talked before I sent it to you. And then I think I messaged that I didn't know what to do with the February one. And that's the only thing I have as an update on my end of things with the book chapters. I'm trying to keep up.
Okay. Yeah, I've been struggling a lot to keep up with the massive email and all that. So sorry if I haven't responded.
It's okay.
So
It's
anyway, it'll
good.
be nice to kind of move to just have grand rounds, even though I think the book will be a nice thing. So
Mhm.
We can exit
Yeah.
for now.
what's that?
We can exit for now and then.
Okay.
Yeah. Okay. Sounds good.
Bye-bye.
Have a good night.
Bye.
Amen. Celebration, Megan. All right.
Thanks. Thank you. Bye.